All right. Hello, fellow platypi, and welcome to another episode of your PS Platypus lecture series. Today, we're going to be looking at the anatomy of the kidneys and the urinary system. Now, a little part of this is the posterior abdominal wall. So that's a prerequisite to understand some of the content we'll be covering today. And that would have been covered in my lecture series for gastrointestinal system, or at least the first part of that. So if you just want to briefly have a look at that section where I covered some of the muscles and major nerves that are involved, that'll be a really, really useful baseline to be able to understand some of the things we will cover today. That being said, though, the kidneys and the urinary system, we like to consider them very separately to the gastro system, aside from a couple of things when it comes to, for example, referred pain. Because as you know, even if I have referred pain in the gastrointestinal region, which is like the stomach area and the abdomen, that can actually be still due to urinary pathologies, and it can even be due to heart pathologies up here in the thorax. So we don't want to be really single-minded when we think about, okay, gastro is just this defined region. We want to also be thinking about things that are above and below. So today, we're not just going to be covering only the kidneys. We're going to try and also look at the ureters and everything that goes down into the bladder to produce our urine. So let's get started. Now, firstly, it's important to understand that the kidneys are bilateral organs, as some of you may know. Much like the lungs, the kidneys have a specific sort of positioning within the cavity that they're in. Now, the lungs are generally quite symmetrical, so you'd expect to find them in a specific height, and they both will be at the same height. With the kidneys, though, they usually do span from around T12 vertebral level to L3, and that's about 3 vertebrae in length. However, the right kidney tends to be a little bit lower than the left one just because you've got the liver on that side. So that tends to push it down a little bit. It's also important to know that the kidneys have some really important anatomical relationships with things around them. And these are useful because of the protective nature of the structures that are around it. So for example, the bones, we know that around the kidneys, if you have a look at this diagram here that I've provided on the right, you'll see that the left kidney tends to be covered by the two lowest ribs, so 11th and 12th ribs, whereas the right kidney tends to be covered by only a single rib, and that's the 12th rib. With the muscles, so this would be kind of more proximal to the ribs, you'd have the quadratus lumborum, and you'd also have that really thick, massive psoas major muscle. And the point of those is to try and protect against stabbing, which I'll talk about in just a second. And then finally, just above the kidneys, you will have the diaphragm. And if you remember back to the different ligaments of the diaphragm, which is not really that high yield, but I thought I'd include it here for completeness sake, the arcuate ligaments, which are just the thickenings of the diaphragm, they tend to land a little bit posteriorly to those kidneys. So I guess if you were doing a surgery and you identified the arcuate ligaments, it'd be a really nice landmark to be able to then follow along to find the kidneys if they're not directly exposed. But again, not really that important for this lecture. So why do we care about all this stuff? Why do we care about stuff outside the kidneys? Well, for one, the bones, which are designed, or they're kind of more on the superior side of the kidneys, they're designed to provide some protection against trauma, just in case you've been punched or stabbed in the region. However, they're also kind of a double-edged sword. And the reason why is because you've got potential fractures of those ribs that can then create sharp edges. And those sharp edges then pierce the very delicate fibroelastic tissue around the kidneys. And then those kidneys, because they're basically sacs full of blood sometimes, they can like pierce, obviously leading to acute kidney injury, and then all sorts of problems can arise from that. The next thing is that if you were to be stabbed in the back, so if you think about the loin region where it's quite exposed, for example, for someone to stab you and then hit the kidneys, you'd have to go through a couple of layers to be able to get there. So a classic exam question might be that you get a cross section. Usually it's going to be like this. So you get a cross section like that. And what will happen is that they'll ask you, okay, what muscle would you have to go through to be able to reach the kidneys? And the easiest answer to put there is psoas major, because it's quite a massive muscle. It's located posteriorly, right behind the kidneys, okay? Which is why when you, like, obviously no one here is going to attempt to stab someone, but if you are ever to see a case, you might realize that it actually takes quite a bit of effort due to the resistance that's provided by those muscles to be able to then reach the kidneys from behind, okay? So it's important to understand in the trauma setting, but in terms of your exams and in terms of things that you'll be covering this year, it's not too important to know. What is important to know, though, is the internal structure of the kidneys, as well as the path that urine takes to be able to go from the kidneys all the way down to your bladder. So when we look at the inner parenchyma, so we're looking at basically the tissue within the kidneys. If I was to take a cross section, you would notice that there are two major aspects. One is the cortex and one is the medulla. So if you looked at the suprarenal or the adrenal glands, you'd know that They also have a cortex and a medulla. And this is kind of a nomenclature that's used for a couple of different organs. So it's good to understand that cortex is generally the outside, medulla is generally going to be the inside. Now, I might just talk about the medulla first because it's not very interesting anatomically. The medulla is just the section where urine will be concentrated. So when it goes from the cortex, which is where filtration and urine production basically happens, it goes through a couple of steps and processes and transport mechanisms until it eventually gets to the medulla, where it starts to get concentrated. Then it gets shunted through into the renal pelvis and then straight down into the bladder, which I'll cover in a sec. In the cortex, though, it's really interesting to note that you've got a couple of divisions. So it's not like everything is continuous. You've got different, even if you look at all these histologically, you will know that they're actually quite different in terms of the tissue density and the structure that they have. So for one, the cortex extends into the renal medulla, as I just mentioned, and then it will divide into triangular renal pyramids, which you can sort of see here. You've got, obviously this diagram is only showing a very simplified version. You'll actually have way more of these because remember, this is in 3 dimensions. You'll have those renal pyramids. And then what happens is, if you have a look at the bottom couple of dot points, the renal pyramids have attached to them these renal papillae. So they're at the apexes of those pyramids. Then those renal papillae will eventually drain into the minor calyces. So those are the things that will collect the urine from the pyramids. And then finally, those minor calyces, as the name suggests, will eventually merge together and then drain into the major calyces, which you can see labeled on this diagram here. Eventually, those major calyces will then go into the renal pelvis. Renal pelvis will then go into the ureters, and then ureters, of course, enter the bladder, and then the urethra, and then out of the body. So that's the pathway that urine will take. Now, of course, it's kind of confusing thinking about where urine actually comes from. Like, what is urine? What is its purpose? That's something you'll cover more in your physiology lectures. So I'm not going to try and tread on those toes here. But remember that the point of the urine is to get rid of the toxins that are present in the blood. That's the major function. So what has to happen is that, of course, in some way, the blood from your body has to interact with all these structures so that those toxins can then diffuse into, for example, the glomeruli, which is where all this collection and filtration happens, for it to then eventually come out as urine. So what we're going to talk about now, or at least in the next slide, actually, I'll go over this first, is the actual arterial networks that are occurring within the renal parenchyma. Before I do that, though, just in terms of gross anatomy, remember that the hilum of the kidneys, remember we talked about during gastrointestinal, the transpyloric plane. What tends to happen is that at that plane, apart from the pylorus of the stomach and a couple of different, L1, L2, that kind of thing, you also tend to have the hilum of the kidneys. Now, of course, in imaging and specimens, that kind of stuff, it's not important to know the relative positioning of the hilum. What is important to know, though, is the structures that pass in and out of them. So as you can sort of intuit, you know that the renal artery and the renal nerve, they're going into the kidneys. So they're going to enter through the hilum. And then the renal vein is draining stuff from the kidneys. The renal pelvis is draining urine from the kidneys. So they're going to exit outwards from the hilum. Much like the lungs, where we kind of would have talked about the different ways, for example, that mnemonic RELs to be able to figure out which of the lungs is the right one, which of the lungs is the left one, depending on the structure and arrangement. You can do a similar thing with the kidneys. However, they tend to be quite similar on both sides. So you don't need to think about left versus right. I like to use the mnemonic VAP. So from anterior to posterior, you tend to have the vein first, then you have the artery, and then you have the renal pelvis that drains the urine. Now, one thing I've kind of noted at the bottom here, which I will just say, is that the kidneys are quite variable in terms of their embryological development. Some people will have kidneys that are all the way down, like right into their pelvis. Some people will have kidneys that are still higher up in their abdomen. And some people will have kidneys where the hilum doesn't actually point medially. It'll point, forwards or backwards or something really strange. And those are not necessarily illnesses, or they're not going to cause anything long-term for the patient. But it's important for you to know when you go into surgery that this patient has these variations, just in case you want to cut something. That'll be discussed more in the embryology lectures. What's important to know for this lecture, though, is the relative positioning of the abdominal aorta and the IVC, because that has implications for the renal arteries and the renal veins and how they're positioned. So the main sort of thing that I want to stress here is it's important to remember that the aorta tends to be more on the left and it tends to be a bit more posterior. Whereas the IVC tends to be more anterior and it's more on the right. So they're not like smack bang in the middle, one on top of the other. They tend to be left versus right. So then it makes sense what I'm about to say next, which is that because the aorta is on the left, it's posterior. the right renal artery is much longer because it has to travel a fair distance to get to the right kidney, and it will also pass behind the IVC, as you can see in the diagram here. Same with the IVC, right? Because it's on the right, it's at the front. We know that yes, the left renal vein will have to be longer because it has to travel more distance. Plus, it'll be in front of the aorta because it's anterior. Now, it's not always anterior posterior. If you follow the IVC further down, it actually, I think, becomes a bit more posterior. But the main point is at the level of the kidneys, this is what the arrangement sort of looks like. And this has implications because if you have, for example, an abdominal aortic aneurysm, and it's a very large aneurysm, what can happen is that it grows and grows and grows, and it can actually constrict or compress the left renal vein. If you have some sort of thrombus forming in the IVC, then you can have that constricting the right renal artery, which is posterior to it. So if you know these arrangements, it's actually very easy to tell why like a left-sided pathology will happen and a right-sided pathology is probably not going to happen, or vice versa. And then you've got, as I said, the hilum. So you've got the positioning. Left hilum tends to be a little bit higher. Remember that the right kidney is lower because of the liver. So left hilum is around L1. Right hilum is about L1, L2 at the transpyloric plane. But again, it's not really that clinically relevant. It might come up in an exam. So if you just want to keep it in your mind, that's good. But the main thing is to understand the relative positioning. This is the important part. So this is something you will cover in a huge amount of detail when you get to physiology. But the arterial branching is really complicated. And it can get really confusing with all the different names that sound really similar. But if you just sit down and draw a diagram for yourself, a similar one to the one that's provided here, but if you can make it a bit more simple for yourself, it'll stick in your mind if you draw it about 3 or 4 times. So the main principles here are that, yes, as I mentioned, you have those gross renal arteries. They start branching off from the abdominal aorta to the left and the right. They do start a little bit underneath the SMA, which you would have covered in the gastrointestinal anatomy section. Now, this is a bit less important, but I thought I'd cover it because I've seen it once or twice in different notes, is that generally those renal arteries, when it hits the hilum, I'm not sure if it's actually, it's not shown in this diagram here because it's a bit proximal, but once it hits the hilum, it'll divide into anterior and posterior. Anterior is the bulk of the blood supply. It's about 3/4 of the blood. And then the posterior is about the remaining 1/4. You have this line called the avascular line or the line of Brodel, which is on the lateral border of the kidney. And the reason why it's so important is because if you want to resect different parts of the kidneys, it means that if you were to hit this line to be able to cut things away, you would not actually hit any arteries, and therefore you would not cause massive blood loss. So it's an important thing, surgically speaking, to know. And I guess for us, it's a bit of a buzzword. So if you hear the avascular line of Brodel, then you know that that's a place where you can have surgical resection without a massive amount of blood loss. In a similar way, eventually these will branch off into segmental arteries. There's about 5 of them on either side. They originate from those divisions to supply the remaining parenchyma. They are end arteries, which means, and I like to compare this to the lungs, where you actually have end arteries and you can therefore do a lobectomy, or you can do you can resect different parts of the lungs without actually causing damage to either the arterial supply or the air supply of the remaining sections that you haven't touched. In a similar way, you can do that with the kidneys. For example, if you have a very localized tumor, if you have localized kidney damage, that kind of thing. So because they're end arteries, you are allowed to do that. Eventually, those segmental arteries will then divide into further divisions. These ones are important to know. So segmental goes into interlobar into arcuate, which is actually, arcuate tends to be the division between the medulla and the cortex, but you will cover that in histology. That'll then divide into the interlobular, then the afferent arterioles, then it goes into the glomerulus, then the efferent arterioles, and then so on. So what I've done here, and this is probably the most, I guess, the best diagram that you'll come across, because it illustrates all the different branchings at all the different, macroscopic and microscopic levels. The main thing that a lot of students will get confused is the interlobar and interlobular. So I guess the way to understand this is that you've got lobes and then you've got lobules, right? Lobes tend to be the bigger sort of triangle shaped sections of the kidney. And then the lobules will tend to be much smaller because obviously they're more distal in terms of the blood supply. So try not to get those two confused. And then between them is the arcuate. That's pretty much all you need to know. And then you go from proximal to distal. Of course, you also have the venous drainage, but generally the names of those are similar and they're not as clinically relevant as the arterial supply, or at least examinable content. So this is what I was saying before. The interaction between these arteries and the actual tubules that form the glomeruli is the reason why you are able to get toxins from the blood into the kidneys in the first place. So that's what urine essentially is. All right. Now we get to the ureters. So we've passed the kidneys. We've now got the urine within the urinary pelvis, the renal pelvis. And now we're getting into the ureters. For the ureters, I guess it's quite simple because it's just a tube that transmits all that urine down into the bladder. But you actually do have these 3 physiological constrictions in a similar way to the esophagus, where you've got those constrictions because of the different things that are around the tube that compress it. And normally in real life, they're fine, like to have those constrictions. You might see them on imaging, which is interesting. But if you have a massive bolus of food, that can be a place where they get stuck, right? And so in a similar way, if you've got urinary calculi that have started up in the kidneys and then eventually drain downwards with the urine, those constrictions are potential places where they can get stuck. So there's 3 major constrictions. You've got the pelvic-ureteric junction. And, sometimes you might see this as uretopelvic, like you can just swap those terms around, but they mean the same thing. That's where the renal pelvis joins with the ureter, as the name suggests. So that would be up here. Then you've got the pelvic brim. That's probably the more important one to understand because it has a nice relationship with the common iliac arteries. So it goes over those. And because of the fact that it's so closely related, you have that constriction. So remember, pelvic brim is basically the bony pelvis, right? Which is why you get that narrowing happening. And then finally, you get the vesico-ureteric junction. Whenever you hear vesico, you're thinking bladder. So this is where the ureter kind of pierces into the bladder. And the cool thing is that because the ureter pierces in obliquely, rather than just going straight in, it kind of goes at an angle. That means that when the muscles within the bladder constrict, which we will go over in the next slide, when they constrict, it actually allows for a very easy way for that bladder, for that ureter to close effectively. If it was not piercing obliquely, you might still have a patent ureter. And what that would mean is that while the bladder is constricting to then eject the urine out from the urethra, some of that urine will actually regurgitate back into the ureters. Some people actually have that embryological anomaly. Sometimes it's in fairly young children, and then what happens is that all that urine backs up into the kidneys. Again, that'll be covered in embryology. The main thing here is that you need to have this oblique entry to be able to prevent the regurgitation from happening. So it's a functional sphincter rather than anatomical one. And then finally, in terms of other anatomical relationships, the ureter tends to travel over the psoas major muscle. You will see that on specimens. You've got that really thick, big psoas major. You've got the ureter traveling over it. The major thing to understand here is that the ureters are always going to be posterior to the gonadal vessels. So an easy way to remember this is using the phrase water under the bridge. So water meaning the ureters, which are taking that urine. That's going to be under the bridge, which in this case is supposed to be like the blood that's traveling through these gonadal vessels. So this is very, very examinable. So if they give you a diagram and they're asking you, like label this particular thing, or if you're in specimens and they want you to identify something in particular, and you're like, oh, is this something that transmits urine or is it going to be blood? Just remember that the one that's anterior is going to be the gonadal vessels. Posterior, because it's water under the bridge, is going to be these ureters. Now we get to the bladder. So the very final stage, apart from the urethra, that urine is going to collect. Of course, like what are the functions of the bladder? It's going to be a place where we get storage of the urine. I think it can hold, like 400 or 40 to 70 or 400 to 700 milliliters of urine, something like that, which is a lot, right? So if you've ever had, moments where you've had to keep urine in your bladder for a long time because you just couldn't find a toilet or something, you would know how much your bladder can actually hold, right? It keeps filtering it, but not necessarily, like it doesn't necessarily need to void urgently or immediately. It can store it here for a while with, certain limits until you find it socially acceptable to void. So what are the different parts of the bladder that you need to know? One is the trigone. So if you have a look at the rightmost diagram, you'll see that there's a dotted line that's been put around. Technically, the trigone is supposed to be, as the name suggests, kind of like a triangle. So it's that area that looks kind of more pale compared to the red surrounding tissue. And that's a place, of course, because it's a trigone, has to have 3 corners. So it connects the fundus of the bladder, which is that part where the urethra joins in, and it joins up with the ureteric orifices on either side. Now, the reason why it's important is because anatomically speaking, it has much smoother walls compared to everything else around it. So everything else is quite rugged, as you can tell. And the reason why is because it needs to expand when urine comes in. Whereas the trigone is very, very smooth and it tends to not expand as much. The detrusor muscle, which is in the wall of this bladder, as you can see in both diagrams, it's a transitional smooth muscle, and it allows obviously micturition. So when the bladder is expanding, it'll be inactive, but then when you need to void, it'll contract and constrict, and then allow that urine to be pushed through into the urethra. The cool thing about this, much like the stomach, those fibers are going to be oriented in a lot of different directions because, of course, in this case, actually like the stomach and also like the heart, right? Because they're kind of like circular organs. And so you need things to constrict rather than just being in one direction, vertical or horizontal. It needs to be all sorts of directions because it wants to constrict centrally, okay? So in this case, you want it to constrict like this so that it can void all that urine out. You also got the two types of sphincters. So you got internal sphincters and external sphincters. This will be probably more covered when you get to the reproductive system in a sense, but I guess I'll cover it here just so that you have some idea of this when you get to physiology. The internal sphincter is autonomically controlled, much like the internal sphincter of the anal canal. However, it's different between males and females. So with males, you've got circular fibers. What they do is they prevent the regurgitation of semen when they ejaculate. When females, you've got a functional sphincter again. There's no muscles this time, so that's why it's a bit different to the male system. It's just that you've got a very, very thin bladder neck, so it acts as that functional blockage to prevent regurgitation of urine. The external sphincters are voluntarily controlled. So that's the thing that you can control when you think it's most appropriate to void. It's a little bit more complex in males. And I guess a lot of these things will be more complex in males because they've got longer urethras. But the reason why it's complex is because you've got fibers from all these different muscles joining. So the recto-urethralis muscle, and then parts of the levator, that should say ani, not uni. So levator ani muscle. Now, the most important clinical correlate when it comes to the kidneys and ureters is referred pain. So this has come up multiple times in exams, and it confuses so many people because the different sources online will say different things. But I guess when it comes to Monash Land, it's just important to know those key buzzwords that they like to say. Of course, when it comes to real life, whenever you have someone with referred pain of the kidneys or ureters, it's quite characteristic. When someone says they've got loin pain, so they're pointing to the backs, their back and saying it's on either on both sides or just on one side, you know for a fact that that's probably a kidney pathology. When it comes to anatomy, just remember that it's about the T10 level, and you're thinking more posteriorly, that's where T10 is around the loin region. Ureteric pain, because of the fact that ureters are not just in one specific area, they go from kidneys down to the bladder. It's a loin to groin pain. So that's classic buzzwordy for ureter pain. That's from T11 down to L1. The most common reason why you can get ureteric pain is if you have kidney stones stuck in one of those physiological constrictions. So let's go through each of them in turn. Firstly, the pelvico-ureteric junction or pelviureteric junction. If it gets stuck there, it's going to be referred to around the L1 region, which is why you get that classic loin pain. And I guess this makes sense, right? Because it's at the most proximal part of the ureter around the kidneys, which we know is around the loin region, right? So that makes sense. With the pelvic brim, so as it crosses over those arteries, so the internal iliac arteries, and also it crosses over the pelvic brim, that's actually a place where you have the genitofemoral nerve. Remember what I told you before with the posterior abdominal nerves, is that, or the posterior wall nerves of the abdomen, is that the genitofemoral nerve is the only nerve that travels over psoas major. Everything else travels posteriorly. So you can imagine that if you have the ureter traveling close to it, if the ureter starts to get inflamed and irritated, that's going to irritate the GF nerve. And what does the genitofemoral nerve do? It goes all the way down, obviously, into the genital region and the femoral region, right? It makes sense. So you will start to get pain around, depending on if it's the left or the right ureter that's being affected, it'll be around those lower quadrants, as well as all the way down to the side of the scrotum in males. In females, it'll be down to the side of their external genitalia as well. With the vesico-ureteric junction, that tends to be a bit more distal. So now you've got referral to the S2, S4, and that'll be around the perineum region. So that'll be, even down to around the anal or the anal cavity, you can have pain all the way going there. In terms of, the kind of pain that you'll get. You'll discuss this more in clin skills. But because the ureters, their job is to push urine through, um, they're always undergoing peristalsis. And even if you have a little stone stuck in there, it's going to think that that's urine or something that needs to be passed. It's going to keep trying to peristalse against that particular obstruction. And that leads to the classic colicky pain that you get. So not only like if you've heard or if you've been in clinic for renal, or if you've heard from someone who is a specialist in this area, you may know that they will describe kidney stone pain as being the worst pain of anyone's life, potentially even worse than pregnancy, which we know everyone knows is like a horrible, horrible pain to go through. This can be really bad. So some surgeons actually like to keep these kidney stones in a little vial because it gives them a bit of a memory in terms of how much pain these people have gone through. And they also look kind of cool. They're like really shiny crystals because of all the urea and stuff like that that hasn't been filtered across. I'm getting ahead of myself. The main thing here is that you have colicky pain because of the peristalsis. You'll obviously also have hesitancy because there's a blockage behind the stone that's being stuck. And because you have that really sharp stone, you can have it grating against the side of the ureters, and that can lead to hematuria because of the fact that that tissue is going to start to bleed out into the urine. A couple of extra things just to keep in mind is that if this is not treated, you can have that blockage leading to obstruction, urine then backflows back into the kidneys, and that leads to hydronephrosis and all the complications that come out of that, including chronic kidney disease or acute kidney injury. So that's pretty much it for this video. There's a couple of extra kidney pathologies that you can choose to look at. For example, polycystic kidney disease, renal artery stenosis is a good one, but I think you cover those more in physiology. So it's not too important to cover them now. The main thing is to understand that referred pain section, as well as the blood supply of the kidneys, because those are highly examinable. If you do have any questions though, please let me know, because I know it's, this is the end of abdomen and gastrointestinal, but there's probably a lot of questions that you have because we've tried to make this as concise as possible. If there are things that are still confusing you, what I'd recommend you do is look at the notes that I've put up on the drive. If it's still not answered there, or if there are still questions or things there that are worrying you, send me a message and I'll be happy to respond. But best of luck for your studies, not just with anatomy, but with everything. I know you probably might have exams coming up, I'm not sure. So best of luck with those. And again, if you have any questions, let me know. See you next week. Bye-bye.